Neurological Institute of Antioquia. The Neurological Institute of Antioquia began its development in 1972 as the League Against Epilepsy in Antioquia, located on the premises of San Vicente de Paul Hospital in the city of Medellin. In 1982, the League started its development as independent entity and began providing services to the population of Antioquia and the whole country with problems such as epilepsy and similar disorders. In 1991, it built the headquarters. In 1996, was consolidated as the Neurological Institute of Antioquia. In 2010, the Neurological Institute has developed Grady, offering high specialist service in neurology and neurosurgery. Our institution is now the only institution in Colombia dedicated to comprehensive in treatment of neurological diseases. The Neurological Institute of Antioquia is the institution of the head of neurology in Colombia. Abnormal movements and functional surgery unit. Our range of functional surgery and deep brain stimulation is based on interdisciplinary approach, with all members participate in making decisions regarding medical or surgical treatment, whilst the sole papers on providing the best care to a patient. The success of the surgery is based on three pillars: proper selection of patients for the medical group, excellent surgical procedures, and specialized DBS programming and follow-up. Patient selection is defined in the medical board, which discusses the history, physical examination, level of a test, and results of neuropsychological and psychiatric evaluation. This meeting is attended by specialists in movement disorders, functional neurosurgery, neuropsychology, and psychiatric. The process begins early in the morning by a specialist neurosurgeon in functional neurosurgery and the neuroanesthesiologist. The first thing done is a preparation on the stereotactic frame. In the Neurological Institute of Antioquia, we have an excellent stereotactic frame, which is prized for reliability and accuracy. It's performed with the patient sitting and by cleaning the scalp, and later with mild sedation and local anesthesia. We place the stereotactic frame, which is fixed to the scalp with pins. Once this procedure is done, the patient is passed to a transport stretcher and taken to a room of images for making a stereotactic CT. This scan has different characteristics to the conventional. The patient is more sedated to prevent movements during the test. Achieved images of this scan are processed together with the magnetic resonance images taken before the surgical procedure in a process called image fusion. This fusion is performed automatically and is early occurring. This analysis is performed by a software specially designed for this type of surgery and allows us to determine the electro entry site and trajectory. They use a soft electrosurgery plan of last generation, which is considered the most accurate ball rate. The result of this analysis also gives us the exact location of the target definition, which can be viewed in 3 dimensions. Again, in the operating room, the patient is covered with stereo-up drapes. They are in place of the point of entry with the coordinate stereotaxia plan and a hole with the diameter of 1.4 centimeters made in the skull. Through this hole, we introduce the microelectrode for neuronal recording. The final location of the electrode is determined by a microrecording. in the analysis of neuronal activities along with ongoing clinical evaluation, performed by a neurophysiologist based on all the structures and allows us to attain maximum clinical benefit from stimulation. This assessment also allows to identify a neighboring structure to avoid eye defect to a programming of the electrode. All information is carefully recorded and analyzed during surgery. Once the electrode is implanted, the clinical benefits are verified, and once again the absence of side effect of comfort. Of the 3 weeks of surgery, programming the electrode is performed by a neurologist expert in movement disorders. This is a medical procedure that we select the best parameters of stimulation, adjust medication, and identify side effects. This process is done in several appointments with permanent supervision of medical team of case of emergency.
Tenía que presentar trabajos, pero nada de deporte. Mi vida era achantada porque pues una niña a esa edad y coja, y ya después del tiempo me empecé a torcer. La mano izquierda también me empezó a hacer movimientos involuntarios y yo era zurda, entonces ya no podía escribir igual, ya tenía que empezar a escribir con la mano derecha. Me daba pena de la letra porque la letra no era la misma. Yo empecé de para atrás, de para atrás, de para atrás. Hasta que en 11 los profesores ya me veían tan mal que me tenían que subir las escalas cargadas, bajarme cargada, no podía bajar al descanso, nada. Todo tenía que ser en el salón. Me operaron y ya muy contenta, ya me puedo parar, ya puedo hacer las cosas por mí misma, no mi mamá me tiene que ayudar ni nada. Puedo estudiar porque estuve 2 años retirada del estudio porque no podía subir escalas ni bajar, nada. Entonces ya muy contenta, la vida cambió para uy, no.
El dejar de tomar tanta droga, ¿no? Y más, como le dijera yo a usted, más libertad para los movimientos del cuerpo, esa rigidez tan tremenda que le daba a uno, ese temblor, porque era que antes de la cirugía, mientras yo no tuviera el efecto de la droga, yo me paraba en un solo punto y mi cuerpo temblaba, parado, sentado, como estuviera. Tenía que tomarme el medicamento para poder estabilizarme y muchas veces tenía que esperar a que me tocara la hora de tomarme la otra dosis para poderme estabilizar, porque había veces que en dadas circunstancias el medicamento no me hacía el efecto que necesitaba el organismo en ese momento, sino que tenía que esperar la siguiente dosis. ¿Por qué lo recomendaría? Por la evolución que uno da, porque le mejora la calidad de vida a uno un 70, o un 80, 85%, mejora la calidad de vida a uno.
Neurological Institute of Antioquia.